So what I'm going to tell you today is what's going on in the Department of Health and Hospitals and how we're using GIS mapping to help us really guide our future and help us make better health policy decisions. Okay, what? Okay. Sorry, there you go. So, aging where you at? So let me tell you a little bit about the Department of Health and Hospitals. We're what's considered a mega agency, meaning that we have our Medicaid services all with our program offices. A lot of states have a lot of these entities divided out. We are all one large agency, so we handle anything from brain-eating amoeba in the water to, we actually haven't heard, we actually have had several cases of that here in Louisiana, to working with people with mental health issues, substance abuse issues, working with people with developmental disabilities and those that are aging, as well as handle all of our acute care through our Medicaid system. There are certainly some good things about that, having everything together. We get a lot of data. We have access to a lot of data through our Medicaid systems, and we have the ability to coordinate a lot of those services that way. On the converse side, it is really difficult sometimes to manage all those different areas and different priorities and different missions that sometimes each of those individual program offices have. So what we try to do is come up with the things throughout the department that are big bets, and we call those our transformational priorities. I'm going to tell you a little bit about what our priorities have been for the last year or two, what we will do for the next couple of years, and then how we're using GIS mapping in each of those areas to help us meet those big bets. So first, building the foundation. We have, over the last 2 years, completely transformed our system of both our traditional Medicaid fee-for-service programs into managed care, as well as all of our behavioral health services. Services for people with mental illness, services for individuals with mental health issues and substance abuse issues. Completely transformed those into a managed care system. So completely taken away our fee-for-services system. We have 5 value health plans and 1 state managing organization for our behavioral health partnership. We have transitioned our human service delivery, that's our developmental disabilities and behavioral health services, to local governing entities. We previously had about half of the state working with local governing entities, the other half state operated. Within the last year, we have completely moved to local governing entity models for all of those human service delivery services. We're harnessing our technology to improve public health and improving our care and outcomes through public health management. Managing smarter. One of the things as an agency, we've really made some major differences in terms of what we feel like our role has been as a health agency. Before, we primarily did direct services. We operated a lot of institutions. We operated a lot of behavioral health services ourselves, and didn't really look at what our role should be as a public health agency and how we could better use our technology and better use our supports to manage public health issues. So we've modernized our vital record system. One of the things that a lot of people are completely shocked with and can't believe that up till about 3 years ago, we were running all of our vital records and our birth certificates on a DOS system. A DOS system that had basically were printed these birth certificates on these printers, and very odd size birth certificates on these DOS printers and DOS systems. And literally, if something broke somewhere, we could barely find somebody alive that knew how to fix those DOS systems. So we've completely revamped our technology. We now have up-to-date computer systems that we're using. We have normal-sized birth records that we can now spit out very quickly using online services. Really changed the technology in terms of our birth and vital record systems. We've streamlined our health inspection processes using pads for inspectors to go out, tablets for them to go out and do their health inspections. We've modernized our public health laboratory operations. We've modernized our Medicaid systems. We do a lot of work from home now, a lot of telecommuting for our Medicaid systems, really managed to save a lot of money, and more importantly, save a lot of time for people applying for Medicaid. Most of our eligibility now is done with people working at home. We've also realigned our Medicaid administration to better manage, and that included really consolidating some of the services, and again, working with individuals in home-based settings to be able to better accommodate the needs of people applying for Medicaid. Last big bet area is promoting independence. We have really changed our delivery system. I mentioned earlier, we operated a whole lot of institutional services. We had 9 state developmental centers that were state operated. We now only have 1. We had 5 state mental health facilities. We now have 2 state operated. And in doing that, we've also transitioned a lot of individuals so they can live in the home community, really beefed up our home community-based services and provided those services now so people can stay in their communities or can transition out of institutions into those communities. We are now taking it the next step and moving that population into a managed care system. We anticipate by next summer is our target right now that we will be able to move those individuals into a managed care system. We also have expanded our coordinated system of care. This is an initiative that we have with the Department of Children and Family Services, the Office of Juvenile Justice, as well as the Department of Ed, where we work with them to coordinate care for juveniles and children who are either institutionalized or in need of institutional placement. And then we're implementing a new community system transformation for people with developmental disabilities, again, aimed at providing more waiver services, more home and community-based services for those individuals. So those are our big bets, the big things that we're working on within the department. So how do we know how we're doing? Before we can really move forward and make changes and know we're headed the right way in policy, we have to have some idea in terms of how we're doing. So traditionally, we've had things like, this is our vital statistics report, which tells us things like, live births by place of occurrence, age group and race of mother, just some general statistics we have on vital statistics. Oops, sorry, let me go back. This is our March of Dimes report card that we get, which, as you can tell, we do extremely poorly. And actually, if you look at any of the national statistics, and I'm sure most of you know this, we do extremely poorly on our national statistics when it comes to health outcomes. We have a rate of 15.6% of preterm birth rates. We were hoping to get to a goal of 9.6. We've got a long way to go. So clearly we're failing in that. But again, that's one of the measures we've typically used. Just sort of straight out statistics telling us how we're doing. It's another thing that we use, the kids dashboard. We have certain measures on there. Again, this is just another way of looking at low birth weight babies. Gives you exactly how we're doing by quarter in terms of the percent of individuals that have, the percent of individuals that have low birth weights. Another way we look at birth stats. Orleans parish birth. Again, this just gives you down to the parish level. Again, what is going on in the parish births over a period of time. Getting to a little bit more technology, we now look at our average nearest neighbor summary. And again, this looks at the nearest neighbors using GIS Esri software, and allows us to determine again where the low birth weights are occurring in the state. So those have been sort of our typical ways that we've looked at. Typically report cards, graphs, sort of straight to statistics. Doesn't really, though, help us when it comes to policy or use of resources. That doesn't really tell me a whole lot of where I need to spend my resources, what I need to do in terms of policy. So what's a better way to do this? We got a lot of data, just showed you a lot of data, and again, I told you that we, as a Medicaid agency, have a ton of data that we have accessible to us. So if we just used our data and wedded to what our data assets are, and a little bit of interpretation, a little bit of visualization, still won't get us where we want to be. You've got to have storytelling with it, you've got to make it relevant, and you have to have ambiguity. You've got to make it fit. And that's the way we'll get actionable outcomes. The entities that can figure out how to get our data science to actionable outcomes are the entities that really will be able to make those policy decisions that will affect and improve health outcomes in the future. So how do we get from big data to the right data? Again, I know many of you have struggled with this. We all struggle with this in terms of how to do this. I think one of the ways that we've been able to do this is clearly through the use of GIS mapping. So can't maps solve the problem? Well, they tell a good story. I mean, I've had the opportunity over the last year to talk a lot about what we've done in the maps and talk about hotspots and how cool it is that I can identify to a neighborhood, find out exactly, where we're having the biggest struggles in terms of things like birth outcomes or attention deficit medications. I can find out, are these particular areas related to schools? Is that why we have such a high medication rate in those areas? So clearly they tell a good story, but they don't solve everything, and you have to be really careful, as I'll show you with this. So this is an area in New Orleans. Reed Boulevard is a census tract boundary. That's on the left here, mentioned that you have the red boundaries. And the names of the neighborhoods is Plum Orchard and Reed Boulevard. On the left, it looks like that you've got maybe some hot spots in Plum Orchard. It doesn't look like the rest of their area is really a hot spot. But it artificially masked a low birth weight hotspot that is clearly imaged on the right. Census tract aggregation create a modifiable aerial unit problem. So you can't just map things and think that's going to give you what you need. You have to then take that information and make sure that you've looked at all of that information to take out any of the issues and do some clustering with that information. So we can, again, it tells a story, you can visualize it, and we know there's a difference, but you've got to have some ambiguity. Because if you don't use the right data, you're going to miss those hot spots. You're going to miss those areas that clearly are problem areas. So maps are a tool, but they're not the only solution. They're just one tool that we can use. So now I'm going to give you some use cases at DHH, in particular to aging in place. Again, I mentioned before, we use maps, we use them extensively for our birth outcomes, knowing where to use our resources. We're now just starting to use them with our ADHD medications to really try and figure out, is it related to certain providers? Is it related to certain schools? How can we, again, start tackling the very high rates that we have of those medications? And the mapping is really helping us figure out where to focus our efforts. So again, we're going to talk about a little bit about the aging in place and how maps can help us get there. So one thing we use is forecasting where our 65 plus population is. We know that by 2030, our 0 to 65 population is going to decline a bit. But what is significant is our 65 plus population is going to nearly double by 2030. Only 16 years away, nearly double our 65 plus population. So this helps us know, what the population is going to look like and where it's going to be at. Where are the biggest areas that plus 65 plus is going to be living in? So clearly you can see that we're the southern parts of the state, southeastern parts are going to have the largest of that plus 65. And if you take it one step further and you start looking at maps and plotting in by specific geographical areas. We use census tracts that are approximately 4,000 people that are in those census tracts. When you look at that, on average, right now, about 1 in 8, about 12% of tracts, any particular tract population is 65 plus, and by 2030, that will be over 20% of 1 in 5 will be 65 plus. So again, we can track where those people are going to be specifically and know where our large areas of need are going to be in the future. We can also look at things like life expectancy. This is a particular area in Baton Rouge I find extremely interesting, and that shows what a big difference there is from North Baton Rouge, and this is all one city, to South Baton Rouge in terms of life expectancy. So if you look at this, in South Baton Rouge, you have a median age of death at 80, average is 75. North Baton Rouge, it's 66, 14 years. 14 years difference in life expectancy from North to South Baton Rouge. Again, it's an amazing statistic. Now, do we know what to do with all of that yet? Do we know why? Sure, we know there's lifestyle things, there's things in those neighborhoods that are going on, but having this data helps us now, again, know where to focus our efforts. Are these people not getting the screenings they need? Are these people, are there other factors that are going on? Don't have all the answers yet, but the maps certainly are helping us get to the answers and figure out, look, I don't need to focus my efforts on South Baton Rouge. I got to focus my efforts on North Baton Rouge and figure out what's going on there. Another thing we can use maps for that helps tremendously, especially when you're looking at how to help people age in place. We know the best way to help people age in place is to be able to make sure that there are adequate providers in the area, whether that's home health providers or that's our value health providers, which are our acute care providers. So we want to make sure that we have network adequacy. So one of the things we can do is figure that out. Well, we ask the providers to give us, what hospitals they've contracted with. And when we first do it, it looks like we got fairly good coverage, that we have adequate coverage because we simply use the 30-mile radius of those hospitals. And so it looks great, it looks like pretty good coverage. However, this is why it's important as you look at maps, you just don't take everything on face value and say, great, we've got coverage. Because in reality, when you apply a more road network analysis, look at the darker green areas, that's what you really have in your network. So you have some gap areas. So it basically revealed more than twice as many were not adequately covered. Before we only thought we had about a 5% network deficiency. But in reality, we have about a 10% network deficiency. So again, gives us the ability to focus on where we've got to build out those networks and make sure that we have adequate networks in place. Same thing as I mentioned before, home health care gives us the ability to map out where we have home health providers, what types of providers are available, how many providers are available in those areas. So currently, we have about 21,000 home health individuals who provide home health services in Louisiana. So we know we need these services as people are aging in place. So the maps you saw before in terms of where people are going to be at, we can then use those, overlay those with what do we have in home health providers. So now we can reveal where we have gap areas in those workers. So you can see that surrounding areas like Shreveport and Alexandria, the darker areas you see there, which Shreveport is up north to the left, and Alexandria is in the middle of the state, we have some real gap areas already. When we double this population, we're going to have some major problems in those areas. So again, gives us the opportunity to know hey, these are areas I've got to get my health plans to go out and really start working with these particular areas to beef up our home health providers. Because if I don't have home health providers, these people are going to institutions that are going to cost us a ton. Or they're going for repeat hospitalizations that also cost us a ton. And more importantly, they're not getting to stay at home. So again, being able to use these maps to be able to determine where we need to put our resources. Another area we look at is telestroke services. Back in 2007, we had very few telestroke services, you can see. Basically, only 26% of our population in the state was within a 60-minute drive time to a primary stroke center. And that's all we had at that point was primary stroke centers. We now built out that network, and we have not only the primary stroke centers, but we also have spoke hospitals that allow that same sort of coverage. So now, in 2013, we have 91% of our population that has a 60-minute drive time to either a primary stroke center or a telestroke spoke hub. So again, gives us the opportunity to figure out where do we have gap areas, where do we need to build out those services, and again, focus our efforts on the areas where we know we've got long drive times, long wait times, saves us tremendous money to be able to have stroke centers. I mean, long-term costs, rehabilitation costs, you name it, when you have access to quick stroke services. One of the other things that we do, we have the ability, we built out with DHH and ULL a partnership which has a web-based environmental public health tracking system. So this system has data on different things like asthma, birth outcomes, air and water quality. You can look at this, and this is available to everybody. It's a public system. It enables users to tabulate and to look. You can go in and put different things in there. Put your parish, which for those of you not from this area, it's a county, and put the things that you're looking for, and figure out where are the areas that have high asthma, where are the areas that have poor air quality. If I am elderly and I have chronic diseases like COPD or asthma, I'm not going to want to live in a place that has a whole lot of asthma issues going on or poor air quality. So again, gives you the opportunity to look at this. You can look at heart attacks and where there are higher incidents of heart attacks. Again, data doesn't give you all the whys and everything that's behind it, but it begins to give us information that can really help individuals make some choices about the environment that they live in. So again, this is just an example. This particular shows an interactive mapping site that shows, I'm not sure if you can see what's on there. Is that, do you know what that is?
Heart attacks.
Heart attacks. Heart attack rate. So again, it doesn't give you all the whys, but it clearly shows where we have a much higher incidence of heart attack rates, and don't know all what's going on in those areas, but again, gives you that information to be able to look at. One of the other things we started to look at is where there are naturally occurring retirement communities. Again, this gives us an idea, a better idea. I gave you sort of the areas where we think population will be and what population will look like. Well, now we can bring it back down to that neighborhood and community level. Naturally occurring retirement communities are basically communities where approximately 30% of the population is greater than 64. And these are areas where either they're set, some of these are again deliberate, but some of them are just where older people have settled and where they'll be. So these naturally, when we can map where these naturally occurring communities occur, again, we can put our resources there. We need to make sure there are home health services, adequate networks close to these, and other services that people who are aging might need that can be close to these communities. So this is a particular one in Charles Park in Alexandria. Approximately, again, 30% of the population greater than 64. So again, that's an area that we have the ability to say, instead of me focusing on the whole state, and if I can map out these areas, then those are the areas I'm going to focus on first. I get the most bang for my buck by utilizing the information I have and focusing my efforts and resources in those areas. One of the things that I think is a future use of maps. Right now, we know physicians are great in terms of looking at our lifestyle factors, our genetic factors, but they don't consider location. And I think in the future, you will see more people looking at location, looking at areas where people are living. And this particular case looks at deaths for prostate cancer. So if I know that there's a particular area that is a hotspot for prostate cancer deaths, what can I do? Well, as a physician, and also as a healthcare agency, I can make sure maybe this is an area we have very few prostate screenings. We go out there, do some focused screenings of prostate cancer in those areas. Again, don't know, haven't made all the connections of this, but clearly, if I can go out there and do some screenings, I certainly have a good chance of improving health outcomes and reducing deaths in those areas that have those high rates. So I think you'll see in the future the ability for doctors to start looking at what geomedical risks are. You know, are you living in a health risk area? What's going on in your area? Our maps can certainly help us get there. And so that you're prepared and the doctor's prepared to help you be able to reduce some of those risks. So again, if I live in an area that clearly has high prostate cancer, that doctor can look at it and say, we need screenings. Could do the same for breast cancer. You could do the same for any of those, asthma, all of these risk factors. I live in one of those areas. There's some things doctors then can look at. And again, not only as a department we can focus our resources, but as a physician, they can focus their resources to improve those health outcomes for those risky areas. So again, I think in the future that you're going to see some of those physicians starting looking at what geomedical risks are. So hopefully you're seeing some of the things that we are doing within the department and what I consider sort of unlimited abilities that we have with mapping to really identify health risk areas, to identify where those hot spots are, and then start evaluating. What does that mean? I mentioned earlier the ADHD medications don't have to do with aging in place, but it's one of the things that is extremely troubling to us as a state because we're the second highest rate of ADHD medication use. So how do we really start tackling it? And if I just took my resources and said, well, we just need to look statewide and figure out what's going on, but now I have the ability to know that in the Lake Charles area, which is the southwestern part of the state, we've got more than a double incidence in that area of people on ADHD medications. We even know what ages and other things that are occurring in that area. So now I can start going to those providers, going to those schools in those areas, doing education, making sure appropriate assessments are done in those areas. And hopefully we then have some reductions of the use of those medications and more appropriate use of those medications. So again, hopefully you're seeing all the capabilities that we believe we've been able to use and that are available for using GIS. So why doesn't everyone use it? Why doesn't everybody do this? It's really not that easy. I mean, it's not, so, you have to have certain things in place for this to work. So if you don't have good leadership that has a commitment to implement, it's not going to work. You don't have if you have a localized business unit that's dealing just with GIS, and it's not incorporated throughout your entire agency, throughout the entire department, not going to work. Everybody has to have access to what GIS technology can do. Because if I have a business unit that knows technology and is doing that, I'm never going to get to the people that are going to think, come up with the theories, come up with the ideas, come up with how to use the resources, and really start focusing our use of that GIS on those important policy decisions. You got to have good capacity and skill sets. One of the ways to do that is have academic partners in advanced analytics, which we have, and working with our universities. We have an amazing ability through our department. Ryan and others within the department have worked with the universities, and we're trying to continue to get people that have GIS capabilities into our department. Again, not to necessarily work in that specialized unit, but to work throughout the department and to begin to use that GIS technology. You have to have access to data. Mentioned earlier that one of the benefits to being a large agency is we have all this Medicaid data that's available to us. Viva la data liberación. You've got to let the data loose. People have to have access to it. And I know there's so many concerns. I deal with this all the time with people not wanting to let go of their data. Within the department, we have entities that don't want to share it with the other agency, the other office in the department. Got to let that data go. There are plenty of ways to make sure it's secure, to make sure it meets all the HIPAA requirements, to make sure that we're not giving individually identifiable data out. But people have to be willing to trust and to allow that to happen, or this won't work. You have to have an information governance steering committee. You can't be, again, that localized unit that's trying to stifle all the information and manage all the information in one little section. Can't start with technology. You have to start with what the business needs are. What it is that you're trying to gain from this. What decisions are you trying to make? What questions are you trying to answer? Then you look at the technology that can get you there. You can't have strict methodologies. We've talked before about what happens when you have strict methodologies. You just keep, you put all that data in and you say, I'm going to look at it a certain way. You don't end up with the data you need. You end up with misinformation. You have to have ambiguous products that allow you to make sure that you've drilled it down to the areas and that you're truly getting the information that you want to get when you're looking at this mapping. So what's the recipe for GIS success? Smart people. I luckily have a lot of those in my department. They make it happen. They really know how to use the technology. They know all the possibilities, or most of the possibilities, and know how to work with our staff members to get those possibilities. Good governance, good enterprise design. You have to democratize the data and tell great stories. I think one of the things that's made it really exciting for us in the department is some of the successes we had, especially with birth outcomes, being able to really focus down to those neighborhoods and find those individuals that are having poor birth outcomes and work on getting to those neighborhoods and those communities that are struggling with this and really putting our resources in those communities and then saying, look, we're making improvements. We've done some really good things based on the data that we got and the ability to focus those resources. Got to be able to tell those good stories. Makes a big difference. I can tell you personally, as I started this off with my lack of technology, I probably have been more excited about this than most anybody in the department in terms of what it can do and what it shows, and just amazed in terms of what the possibilities are, not just possibilities in terms of what we're doing right now, but possibilities for the future. And again, the ability. We have such scarce resources. I have a department that has downsized from 12,000 employees to less than 6,000 employees in the last 5 years. So we've gone under tremendous changes, tremendous reorganizations, reductions in staff. My resources get slimmer and slimmer. So when I now have to make policy decisions and decide where to focus those policy decisions and where to really focus my efforts, there's nothing better than GIS mapping to help me do that. So I think I'm going to turn it over to Angelica, who's going to talk about her perspective on this. So thank you.
Well, welcome. I know I'm the only thing that's between you and some amazing lunch and pretty bar from out here. So I will try to keep this concise. And my way of storytelling is a little different. Because if you were here yesterday, you would have learned that I don't have a technology background. I'm the social worker on the team. I'm the resident social worker. So my job, along with helping to educate cities and counties, parishes, states, and other countries about how to use this type of technology in their work, I also work to educate the other fields, other domains outside of me. We work in public works. We work in mapping the ocean floor and every intelligence and public safety industry possible. But I help them to remember that they're working for humans. And so it does come back to human services. So I have a good job. For those of you who are not familiar with Esri, we are the world leader in geographic information systems. So we're GIS. So what is GIS? It's we're taking all that mass collection of data that you hold and putting it in a way that you can analyze it, visualize it, share it out, and collaborate with others. Not only make great decisions, but to change the future. And this is my brief. Why is it so compelling? Because it communicates. Bar charts and graphs, they're nice. Spreadsheets get really involved. When you're a policymaker, do you have time to sit through 30 spreadsheets and figure out what the story is? No. But a quick map can help you, or even a story map, and I'll show you an example of those later. And the technology is rapidly evolving and constantly becoming easier and more intuitive, so we're continuing to expand on our GIS platform. And we'll talk a little bit about spatial analytics later, which has become a very powerful tool, which used to only belong with the epidemiologists in the health departments. And now it's going to everybody. If you have an Excel spreadsheet that you can work at your desk, you can do analytics and you can map. And that's something new for folks in our field. But I'm going to change it up for a moment and tell you why this concept of aging in place, why GIS help with that concept. It's compelling, not just folks here, but to me. Meet Lily. Lily is my grandma. And you can see the 9-year-old photo bomber in the back. That's my niece, Kylie. Here's my favorite picture of my grandmother, so I like to film. Lily is 84 years old. She is a widow. She has been on her own for approximately 8 years. She and my late grandfather worked really hard their entire life, retired in the home of their dreams. This beautiful tri-level home with basically 2 backyards, a pool and a lawn, just a great family place for everyone to gather. Well, over the years since my grandfather's passing, my grandmother's health has kind of deteriorated. Part of it's due to her own lack of care earlier on in life, and part of it is just a normal process of aging. But one of the things that has not changed, which is a constant with Lily and like many other folks, is they're fiercely independent. And they do not want to move. They do not want to have other people making choices for them. This is where GIS comes into play. This is Lily's neighborhood. This is in the outskirts of Los Angeles, the home of sprawl and suburbs. As you can see towards the southern end, in the star, that's her neighborhood. If you notice, it's also bordered by hills, so she's kind of up, elevated. It doesn't look like she's that far from the freeway, but truly it takes, probably myself, 15 minutes to walk to the main drag, and another 30 minutes to get down to the freeway, because it's a pretty steep hill. So my grandmother, her walker, that's not happening. Wheelchair, not going to happen. So there's some supports that have to be built in. This is her routine. We have paratransit that helps her with medical visits when family is not available. We have routines such as grocery shopping, prescription refills, for church, for daily chores. But what's most important to her, when we live in that big net circle, it's her social life. My grandmother is a proud card-carrying member of the Red Hat Society, and she loves hanging with her ladies and all of her other senior activities. But that I circle not just because it's cute, but because those are activities that are rich and warm and help her being a happy person and help towards her mental health. And anybody who works with an aging population understands good mental health is just key to helping keep up the physical health. So connections, remember connections, that's what's important. So for my grandmother, how does technology help her? In a couple of ways. Some of the things we help her with, some things she's able to do on her own. My grandmother is a whiz on an iPad, by the way. She can play Angry Birds, and Candy Crush is evil in her mind. But she's also learned how to schedule senior transport pickup. She can request refills. She can do some banking. Sometimes we want to help her because she goes a little crazy on Zappos and Amazon, but you know what? She's 84 years old. This is her money. She's making her choices. Now I'm going to switch gears because we need to start planning for all the other lilies that are coming on board. As the secretary touched on a little earlier, this segment of the population is the fastest growing. Over the next 16 years now, there's going to be a 77% growth rate in this group. The folks that are going to be over 65 years old. We better get cracking, and we better start figuring out how do we help people successfully age in place. But in order to start, you might want to figure out what that is. And so this was taken from the Nova Institute, who did a great report, which I'm going to show you some slides, which might be kind of interesting, especially for the folks here in Louisiana. And we're talking about what makes a successful community for folks to age in place. This is a very simple things that anybody would want regardless of their age, but have become more necessary the older you become. You want a safe and healthy environment, you want to have connections, you want to have your friends, your family, the right type of living arrangement. Sounds about right. But we notice as we get older and our living situations change, our neighborhoods change, our options change. We have to make sure that we provide those options at every level of ability and income for our older folks. So who's doing it right? Well, based on Milton Institute's Essays for Successful Aging, look who's number 14 on their large metro areas in Baton Rouge, Louisiana. What I loved about this report is they took a whole collection of indicators, and there's sub-indicators built in there, and did some scoring. Even more so, we pulled down into the smaller metro area, and look who's there, Lafayette. Those are the only two cities in the state of Louisiana that made this list. I think that's pretty amazing. 37, not a bad number when you're looking at it across the nation. Most importantly, you see on the left-hand side the scores that go along with the indicators. That's for you as a community to take a look at where you rank along each of those indicators and say, well, if we do one or two of these things, that'll make an improvement. That'll increase the health and wellness. That'll improve on transportation. That might increase employment opportunities. It's kind of a starting point, a foundation, per se. So foundational information is important. But what do you do with it? You map it. So here's where we come to GIS. Mapping helps you understand and compare the places. You start to look at how places are related. Looking at patterns, things that didn't emerge when you're looking at a spreadsheet pop out at you when you're looking at a map. You can make predictions where certain members of your population are going to be, how those changing demographics are going to look 5 years from now in a particular neighborhood or region. You can plan more effectively. And also looking at your automated business systems and how you're processing information. All the spatial analytics behind GIS help you accomplish them. Helps you answer the where. Because you can take your data, customize it. So this is a data browser within our ArcGIS and community analyst programs. And I always tell people that the maps that come out of Esri technology, that's just a pretty outcome. Power behind all that is the data that underlies it. Now this is data that you mesh with your important data, whether it's patient data, community data, planning, resources, finances, whatever that might be, to get a true picture. And you can mesh it up with over 2,200 health variables alone. I've lost count of all the numbers of the other things. But there's consumer spending, business information, And he said it's important for you to figure out as a community, how do you help folks age in place? You can look at something as simple as financial indicators and see how many of your 65 and older, what percentage are living in poverty? What are the numbers of folks that are relying on reverse mortgages? Is that a trend that's increasing? And figure out why. You can look at, are there enough banking institutions in your communities? You can map something as simple as adding in their annual income growth. We haven't left anywhere, we've just changed the data. Median household income. Why is that important? Because you start to understand what's going on in that neighborhood, what people are able to afford. Do we have proximity to grocery stores for folks to walk to as they age? Do they have grocery stores at all in their neighborhood? Is there senior transport available to get from there? I worked with a community out in California that started to do some planning and realized that a whole neighborhood in their community had just been cut off. While the whole city was growing and booming, for some reason this part of the city had remained stagnant. And when they started mapping it out, they realized that transportation for some reason stopped right at this line. That YMCA soccer for kids stopped at this line. And it was just old planning from generations ago that no one bothered to revisit. When we started mapping it, we started seeing the varying health indicators from one side of the community to the other. That's when policy decisions started to change, because the data was in front of them and they could see it. We look at other things that are part of the successful aging community's education and employment. People are starting to decide, do I wish to stay here? Or maybe we should move. Maybe we should move now while we're in our 40s and 50s so that we can live in a place that we can age in place. So seniors or up and coming seniors are looking at what your unemployment rates look like. Because if you have a high unemployment rate, probably means your senior employment rate is pretty bad too. We pay attention to health. Where are our hospitals? Do we have enough hospitals? Do we have enough primary care providers, enough beds? But most importantly, we're starting looking at, do we have enough services? And we know as we start getting into geriatric care, we're looking at dialysis centers, Alzheimer's care, long-term care facilities, aged care facilities. Do we have enough? Are we planning appropriately for our population? Because we know how many of them are coming on board and where they're going to be. So maybe now we need to start planning for the next 5, 10, 15 years and where all the support services are going to be located. Here's an example of how you tell that story. This is a story map template. These are templates that are part of our platform. And you can plug in any of your data, but it's a way of taking all that complicated bits and numbers and putting it in a way that you can educate not only your own staff, your department, your policymakers, but even put online and share with the public. This is how we're spending your money, and this is why we're spending it this way. Because on this side, where it's bright orange, those are areas in which there are more than 17,000 people, but yet there's no primary care provider. Maybe we need to pay attention to those areas and start looking at other health indicators. We can flip on the other side and show the availability of primary care providers to a larger segment of the population. Just really start taking a look at why and who's not getting served, or where there are no services, and be able to communicate that in a way that people can understand, appreciate, and move forward with. So why are we doing this? Because this population is coming, and we need to be ready in every part of our life. We have 1 in 3 boomers shop online. They contribute $7 billion with their online shopping every year to our economy. 1 in 2 of them are on Facebook, and they're the highest growing population of TV watchers. Why is that important? Because that's where all your advertising goes. So what do we need to do? Need to look at our data. So let's start talking about the data. If you were to take all the information you have and you drew it on a map, this kind of look like points on a map. A little useless, a little crazy. And we say, it's pretty much map measles. But you can turn that into this. Start doing a little clustering, getting a little easier handle on the data. And if this was live, we could drill down and start going into smaller clusters and getting a real picture of what's going on in a particular region. You can map to a region. Again, this is not something that your charts are going to show. You can map to your states or zip codes. Most importantly, you can start mapping to regions that are important to you, that are customizable to you. In certain parishes or counties, there's regions that are specific to them. Like for Los Angeles County, they group their health districts very differently than the other counties around them. So they have their own boundaries. They're called spots. I'm sure that that's the same everywhere you go. You can also take that data and start looking at hotspots and heat maps. Just understanding more than just the density, but where the clear problem is occurring. So you can start changing the way that you intervene for outreach, interventions, and help. And gain some insight into what's going on in particular populations. You can drill down into a particular census tract and get an idea and say, I need to understand what's the income level in this tract. What is the demography of this area? What is the purchasing power of this region? What's the insurance levels like? These are important bits of data that help you make decisions. And most importantly, you can start taking that data in any which way and make it work. Whether you are doing freehand polygons, whether you're using the census tract information, whether you want to see drive times from particular hospitals or community centers, senior centers. If you want to look at distance, drive time distance, or just by miles, you can take and look at your map however you need to, and the data pulls directly from that source. So at Esri, one of the things that's really unique about our company is that we have a whole team of demographers and statisticians, and they pull all this data together for you, so you don't have to look at 10 different sources. And it's census data, current data, and 5-year projections. So you can really truly start planning. It's just a quick snapshot of some of this stuff. But most importantly, you can put a face on that community. Now, I like to tell people it's called geo-enrichment. It's taking the information you already have and finding everything else out about your population. You know where to place clinics, where to maybe decommission something. Take a look at why, who's there, who's going to be impacted, not just fiscally, but what is the impact on the community. You can get information on any particular location. You don't even have to get a map. You can get a targeted marketing segment profile. Now, people say it's a little scary. You can zoom down into my census tract and tell me what the median housing is, what are my purchasing preferences, what kind of car I might drive, what kind of television shows I watch. Yes, but you know, Walmart and Starbucks and Nike and all those other huge companies have been using this information to figure out where to place this Nike tennis shoe for you to purchase, where you're more likely to purchase it, where to open your next coffee shop. I'm saying take this information, take your data, and use this power for good. Use it to improve the health and the well-being of your community. You can take that data and see their word profile. Sometimes you just want to see numbers. Yes, not all net maps are not the answer to everything. But sometimes you would like to see projections. And this is an example. It's an older example. But I just wanted to include it because we talked about it the other day, how you really can't personalize your reports. So as you can see, it's at UCLA's School of Public Health. That's the logo up there. It's an Esri report, yes, but this is coming from them asking about data in their own community. So obviously this was done back in 2011 because they pulled from the recent census, they have their 2011 data, and they have their projections 5 years out. So anything that you've asked of that segmentation, it's as much data, sometimes more than you'd like. Again, your map is more than just a pretty picture. I mean, truly, if you have the opportunity to play in here, you start to understand that this is an opportunity to query your data right within your map. And as you query the locations, all of the other charts start to change in unison. So what you're doing is you're being analytical. You now have a very serious and important analytical tool at your fingertips. And you're working from your mouth. Okay. You can take it from the back, from the simple, from the analytics, something that's really scientific. And that's There we go. You can look at maps that are creating larger business systems and plug them into other places. You can share them across systems because you have one department using IBM Cognos, another department using MicroStrategies, anything, SharePoint, CRMs. You start looking at what's the common denominator, geography. You can break down barriers, and you can work a little more collaboratively by sharing data and visualization. So again, why is mapping important to me? Because one day that's going to be me and my grandmother, and I want to have those choices, and I want to live where I wish to live, whether that's in the house that I grow old in, or it's a neighborhood that I wish to live in, with all the supports that I need, with my doctors, my friends, my place of worship, and the things that make me a happy, healthy human being. And so I leave you with this. The work that you do is not only for my grandmother, it's for your grandmothers, and it's for everybody else's as well. So thank you.
We're going to do a little Q&A, if you're all right. Questions? Sure. I'm like, uh-oh.
This one will be the tapestry segmentation I'm familiar with, but I think it's amazing. There's a lot of value there, untapped value, for those who aren't aware of it. We saw one of the segments, segment 7. I can't recall offhand how many of them there are. But can you say a little bit of something about the segmentation, and how many there are, and kind of how they're built?
Oh, sure. There's, I think, about 65 different segments, market segmentations, and it truly is a profile of these different areas. And you might have a zip code and think, oh, all the zip code is the same, and it's not. Depending on the census tracts that are built in there, you will have a variety of folks. And so the beauty of looking at all of that data, again, preferences of how a person gets their news or where they might shop, that's important as well, especially if you're looking at community education or interventions. An easy example is the local hospital, the school of public health wanted to do a flu shot clinic in this primarily lower income neighborhood. It was very mixed of cultures and languages, but they weren't really having a lot of success. So we kind of played with tapestry with them, and they understood this particular neighborhood that they were not getting any response from. Pulled the tapestry and showed that this was primarily a Spanish-speaking community. Most of them received their news not through paper, not through internet, but from this local Spanish language radio. And typically most purchases were made at the local Walgreens. And so that's how they targeted. They partnered with Walgreens, they partnered with the radio station, they started getting their information. They still did some of the other things, but they just changed their way of outreach, and it made a significant difference in the outcome. And so, I mean, that's just a tiny way of using it. And like I said, commercial entities have been using this forever to sell you stuff.
And this is, unfortunately, the last question. We're running a few minutes behind.
We have a big chart if you want to see all of them at one shot at our booth. So please come.
Thanks. This is a question for the Secretary. I was particularly honing in on the low-work like return delivery information and the hotspot that you pointed out. It wasn't evident one way, but was another way. But it struck me that could be quite dynamic information, and I wonder, have you been, as the state, been doing this long enough now to be able to see those kinds of changes over time? Like one low birth rate infant in the neighborhood 1 year may change it if it's not there next year.
We haven't really had long enough time. I mean, we're getting there. We're getting more and more data in terms of being able to look at it over time. I mean, what we have is we've used that data to go into some of these neighborhoods, but to see the outcomes, we haven't seen the outcomes yet. So hopefully soon, though, we will. You'll see some big differences in the outcomes.
All right. Thank you very much. Thank you. So some quick housekeeping, if you don't mind. First, we have 4 food trucks outside.